Hello, my name is Brandsma and I'm a resident in Paediatric Neurology at the University Medical Center in Groningen, the Netherlands. Today I would like to discuss our paper entitled Reliability and Discriminant Validity of Ataxia Rating Scales in Early Onset Ataxia, as published in the April 2017 issue by DMCN. Early onset ataxia, or EOA, concerns a group of rare ataxic disorders manifesting before the 25th year of life. This diagnostic group covers a wide heterogeneity of disorders regarding age of onset, inheritance, and etiology. Consequently, the phenotype is also heterogeneous, consisting of an EOA with a core ataxic phenotype, in which ataxia is the core symptom, and an EOA with a comorbid ataxic phenotype, in which other movement disorders concur beside the ataxia or could even prevail over the ataxia. In children, the severity of ataxia could be assessed by using ataxia rating scales like ICAR, SARA, and BARS. These ataxia rating scales are important for the longitudinal follow-up of the disease course and for the objective measurements of therapeutic strategies. Ataxia rating scales are reliably accessible in adults with ataxia. However, in EOA patients, these data is still lacking. In children, we have shown that ataxia rating scales are not only influenced by ataxia but also by age and muscle weakness. These factors induce a confounding influence on ataxia rating scale scores and lead to an insufficient discriminant validity. In the present study, we aimed to investigate the reliability and discriminant validity of ataxia rating scales in early onset ataxia. Our hypothesis was that reliability is good, but that in a comorbid ataxic phenotype, concurrent movement disorders influence ataxia rating scale scores as well. In our study, we included 38 patients diagnosed with early onset ataxia. 3 independent pediatric neurologists phenotyped the primary movement disorder they saw in those patients. After a latent time interval of 6 months, they quantified ICAR, SARA, and BARS according to official guidelines. We determined intra-observer agreement by calculating an interclass correlation coefficient, and to determine the discriminant validity of the ataxia rating scales, we compare total ataxia rating scale scores with the groups of the defined phenotypic primary movement disorders. We subsequently also determined, using a multiple regression analysis, the most influential factor on the total ataxia rating scale scores. Our results indicate that the reliability of ataxia rating scales are high, as demonstrated by an excellent inter- and intra-observer agreement. For the discriminant validity, please let me show you the next figure. In this figure you see 3 graphs representing the 3 different ataxia rating scales, ICAR, SARA, and BARS. On the y-axis you see the total ataxia rating scale scores, and on the x-axis you see the phenotype primary movement disorder. As you can see, there was no significant difference between those groups. As demonstrated by the multiple regression analysis, the only significant influential factor on total ataxia rating scale scores was the severity of the primary movement disorder, independent of ataxia was present or not. In EOA patients, ataxia rating scales reveal high inter- and intra-observer agreement, reflecting good reliability. However, the discriminant validity of ataxia rating scales are insufficient to discern between ataxia and other concurrent movement disorders. This implicates that in EOA with a core ataxic phenotype, ataxia rating scales are a reliable biomarker for the assessment of ataxia severity. However, in EOA with a comorbid ataxic phenotype, ataxia rating scales are confounded by other concurrent movement disorders as well. Forthcoming insight in the ataxia rating scale construct seems important for uniform interpretation in future trials, especially in cases where small fluctuations are considered as indicators of ataxia improvement. One should include homogeneous EOA patient groups regarding age and movement disorder phenotype. To conclude, ataxia rating scales are reliably applicable in EOA patients. Despite the high reliability, the discriminant validity is insufficient, especially in the EOA with a comorbid ataxic phenotype. For reliable interpretation of ataxia rating scale scores, we advise that the score should only be interpreted in homogeneous EOA patient groups.